A little hot.
Says that we should hear some music, but we're not hearing anything. MAmoun, can you hear any music?
Yeah, it's very faint. It's very faint. So, Dr. Habala, do you want to take over until Samer is here?
You're the president, and you're the. I think
Sure.
you should, as a president, you should welcome everyone, and then say this is our first visit.
Sure.
And
Let's
probably most. So is Ahmed ready to present, or what's his situation?
Right, I think Ahmed is the first presentation. Well assembled, we're on, everybody can hear us, and our webinar started. So, good evening, everyone. I'm Dr. MAmoun Elbashir. I'm the current president of the PAVSS, and we're really excited to start this year with a full program of academic activities, starting with this journal club. And this would be the first of a number of impressive activities throughout the year. And definitely we'll hopefully finish the year by our impressive to come Congress in this year in Muscat, Oman. So without further ado, let me start with, the brief program for this journal club. So we do have two presentations to discuss, or two papers to discuss, and we'll start with the first one being presented by Dr. Ahmed Zabi, who's a vascular fellow from the Royal College of Surgeons, Dublin, Ireland, he's going to sort of present to us network meta-analysis of endovascular treatments for lower extremity arterial disease, stratified by lesion location and severity. He's being supervised and mentored by Dr. Samer Koussayer, who's probably with us online. So not to waste any more time, the floor is open to Dr. Ahmed.
For this introduction, and I would like to thank the organizing committee for accepting my presentation.
Can you try to raise your voice, because we can't seem to hear you very well?
Is that
volume?
The volume, Dr. Ahmed.
Is that clear now?
It's better, but it's still a bit low.
Might change it to.
Is that better now? Sorry.
Yes, absolutely. Excellent.
Okay. Thank you for this opportunity to present this brief journal club of endovascular treatment for lower extremity arterial disease network meta-analysis. I would like to thank the organizing committee and our consultant in the panel. I am Ahmed Zabi. I'm a vascular fellow in RCSI Dublin, and I'm also an employee in King Fahd Specialist Hospital in Saudi Arabia, Dammam. I would be talking about a paper which is still in press for Journal of Vascular Surgery. It was accepted to be published in 2025, and it will be published later this year. The authors are multi-center academic vascular surgery department in China, including tertiary hospitals and university hospitals. The journal impact factor is around 4 to 5, and the study design is network meta-analysis of randomized controlled trials. So the knowledge gap was tried to be addressed in this study due to the wide range of endovascular device available for lower extremity arterial disease. However, optimal endovascular strategy often remain uncertain and operator dependent and preference, highlighting the need for the comparative anatomy and severity driven evidence. The current latest
Dr. Ahmed, can you share your slides, please, with us? There's a share button.
It's not shared now.
It's not shared at the moment.
Sorry.
It is now.
Oh, sorry. I thought that it was shared. So the knowledge gap work, it was tried to cover in this subject that a wide range of endovascular are available for lower extremity arterial disease. However, the optimal endovascular strategy still and remain uncertain and operator dependent based on the preference without direct guidance with evidence-based anatomy and severity driven choice. So the previous evidence in 2024 guidelines recommended revascularization if conservative therapy or management failed, but without providing limited lesion and clinical severity specific guidance on a device or therapy selection. The author aimed in this study to establish an evidence-based framework for endovascular device selection and lower extremity arterial disease by performing a stratified network meta-analysis of randomized controlled trials. The setting for this study was with population of adults more than or equal to 18 years old with symptomatic lower extremity arterial disease in form of intermittent claudication and critical critical limb ischemia, Rutherford from 1 up to 6. The patient were enrolled across 82 randomized trials and 112 reports. Trials conducted in multiple countries worldwide, including Europe, North America, and Asia. The setting included tertiary referral centers and academic vascular units. With regards of the inclusion and exclusion criteria and the paper, the inclusion criteria was prospective randomized control trials and adults more than or equal to 18 years old and symptomatic lower extremity arterial disease in form of claudication, intermittent claudication, and critical limb ischemia. De novo arteriosclerotic lesion in iliac and femoral-popliteal and infrapopliteal arteries with minimum follow-up of 6 months. The exclusion criteria was non-randomized studies and instant restenosis, thrombotic lesions, and hybrid cases, non-atherosclerotic diseases, and multivessel or multi-level planned interventions. Total reports and publication was screened was beyond 15,000, and primarily were excluded more than 14,400 publications, and then it was assessed for the eligibility with a number of 706 publication, and around 600 were excluded due to non-randomized trials and no evidence of comparison of devices, and or use the other endovascular devices such as cryotherapy. And we ended up, or they ended up with the studies included in the review 82 randomized control trials, with reports included studies 112 reports. So the intervention was or were compared in these studies were bare metal stent, drug-coated balloons, and the drug-eluting stent, cover stent, atherectomy plus minus or combined with drug-coated balloon, balloon angioplasty and cover stent, and cutting balloons. The primary outcomes were addressed in this study were 4 primary outcomes: primary patency and target lesion revascularization and reintervention, major amputation in form of any amputation above the ankle level, and all-cause mortality. In form of, with regard of this statistical analysis, the author used a conservative network meta-analysis approach that account for strict variability and test for validity of indirect comparisons, and confirm reliability through sensitivity analysis with the stricter confidence thresholds. The results of the study, the population was 82 unique randomized controlled trials, included 12,796 patients with symptomatic lower extremity arterial disease. The total excluded studies were beyond 15,000 due to ineligibility or exclusion criteria, due to the reasons of non-randomized studies or non-atherosclerotic disease or instant restenosis, hybrid procedures, and multi-level lesion interventions, and insufficient follow-up or outcome data. The primary outcomes and comparison between the 4 subgroup anatomical clinical subgroups. The first subgroup is intermittent claudication with iliac lesion. It included 4 randomized controlled trials with total of 696 patients, and it compared 3 therapies, which are the bare metal stent and cover stent, and the balloon angioplasty. So it concluded that improved patency and the cover stent compared to the balloon angioplasty and bare metal stent, and these results were with a follow-up from 12 to 60 months follow-up with improved patency to the side of the covered stent. With regard of the other outcomes, no difference was noticed in the reintervention and amputation and mortality. As we see here in the left lower side of the slide, with 60-month primary patency follow-up, it showed that the cover stent is better and it improved the durability On the right side, the dots are representing of the number of patients included in that intervention, and the thread connecting these interventions is representing the number of trials that were conducted and comparing these two interventions. The second clinical anatomical subgroup is intermittent claudication in a patient with femoropopliteal lesion, and it's conducted 50 randomized controlled trials with a total of number 8,101 patients, and it was comparing 9 devices. So the time-dependent hierarchy was observed, and for the short-term patency from 6 to 12 months, it showed atherectomy and drug-coated balloon better outcome, and on a longer run follow-up up to 24 months, the cover stent was better as more durable over 24 months. And the drug-eluting stent showed the best result over 36 months follow-up. With regard of the re-intervention and target lesion revascularization, the drug-coated balloon showed best early prevention. With regards of the safety outcome and amputation and all-cause mortality, 48 months follow-up showed no difference in all of the compared therapies. For a critical limb ischemia subgroup with femoral popliteal lesion, 5 randomized controlled trials were compared and conducted with 461 patients with 5 therapies mainly compared versus balloon angioplasty. The results showed that no difference in the short-term outcome, and the balloon angioplasty on a longer term show inferior results. The perimeter stent and drug-coated balloon provide better durability over 12 months and 24 months follow-up with favor of drug-eluting technology. There is no difference in the major amputation or all-cause mortality risk on 12 months follow-up. For a critical limb ischemia femoropopliteal lesion, these first plots showed that result which we just mentioned about the drug-eluting technology over a longer run follow-up. And for a critical limb ischemia subgroup with infrapopliteal lesions, 24 randomized controlled trials were included with total of patients 3,164 patients, and comparing 5 different therapies. The drug-eluting technology is superior and compared to the other technologies. Drug-eluting stent and drug-coated balloons improve patency and reduce the re-intervention compared to the perimeter stent and balloon angioplasty. The drug-eluting stent associated with a lower major amputation rate at the 12 months follow-up. No significant difference in all-cause death or mortality was observed among all therapies at any time point.
Next.
The conclusion of these studies showed that endovascular device selection in lower extremity arterial disease should be individualized, as outcome varies significantly by lesion location and the clinical severity and follow-up duration. An intermittent claudication covers stent provide the most durable patency for iliac lesions, while femoropopliteal disease demonstrated a time-dependent hierarchy with a combination of therapies, superior short-term and dedicated stent superior on the long term. And critical limb ischemia, femoropopliteal lesions, no single optimal strategy exists. However, balloon angioplasty alone is inferior to other advanced therapy with both bare metal stent and drug-eluting approach. And a critical limb ischemia subgroup, drug-eluting technology are central for infrapopliteal disease, improving patency and reducing re-intervention with drug-eluting stent showing potential limb salvage advantage over drug-coated balloons. The strength and limitations of the study. Strength points was observed the largest network meta-analysis in the lower extremity arterial disease up to date, and it is stratified by lesion location, disease and disease severity, which give better applicable chances and value. Time-specific outcomes from 6 to 60 months allow understanding of short and versus long-term device performance, and direct clinical applicability, as it is precise and clear comparison between four different lesions with specific clinical severity presentation. The limitation is the class level comparison only. It's not specific commercial devices, which might be different between device to another. It is a limited number of trials for two subgroups, femoropopliteal critical limb ischemia and iliac intermittent claudication compared to the other groups. It is excluding the complex cases and no instant restenosis, multi-level intervention or hybrid procedure, which is limiting the application and the practice, as these cases are not applicable and it might not reflect the same results of this study. So from appraisal point,
Ahmad, I think we can stop here. I mean, it's okay.
Yeah.
I'll give time for discussion. You can run in late,
Sure.
So tell me, what do you think, Ahmed, about the paper? Give me what's your impression about the paper.
Well, the paper
is a good paper, is bad a paper. What do you think?
It is a good paper, and due to the lack of other paper with the same number and the same preciseness, I believe it's a good paper to consider, and it's applicable to the practice. This is the most thing.
Do you think this will change our practice? I mean,
I believe
what we do now.
Yeah, I believe it might. It will affect and it will guide our practice for these groups and for these cases.
Okay. Thank you very much.
Thank you, Dr.
I'll open for questions. But the only thing I have, again, this paper does not reflect the real world, because the real world, you never see like a single, lesion. Always in vascular disease, multiple level lesions, and this in this trial, I don't see they exclude these multi-level interventions, or multi-level lesions from the study, which can affect your outcome. And the second thing, as I said, is not no specific commercial devices, and every device sometimes has its own data. But I think it's a good paper to give you an idea what's going on, because it's very hard to run a study in lower extremities because huge variation in the multiple level of, disease, multiple, commercial devices we have, even drug-coated balloon. Sometimes every balloon stand by itself, it has its own data. You cannot compare drug-coated balloon, in one device with other one coded drug-coated balloon other device. So a lot of variations. That is why it's very hard to run a good study in lower extremity intervention. But I think it's a good meta-analysis, try to get at least an idea what's going on now. But I will leave now the, open to questions. Prof. Jamal, what do you think, Jamal?
Well, first, nicely done, Dr. Ahmad. Nice presentation, very clear. I think one of the main drawbacks that I have is the lack of correlation with the severity of the lesion. So specifically, I will ask Dr. Ahmad, if you have now a patient with a claudicant with a task A lesion, one area of common iliac stenosis less than 5 centimeter, not occluded, it's 90%, 95% stenotic, short segment. Are you going to put a covered stent in that patient, or are you going to put a bare metal stent? I think there is a difference between having a task A or B lesion versus having a task C or D lesion in choosing covered stents in the iliacs, at least in my practice. So I would certainly be interested in hearing what the other panelists would comment on that. Similar things about the infraangular and then mainly infrapopliteal. I mean, where's the role of the availability of drug-eluting stents for tibials, and if you have a focal area of tibial disease that you balloon angioplasty for a non-healing ulcer in the foot, would that be enough? And how does that compare to the costs of treating these patients, especially in our part of the world? Thank you.
MAmoun, what do you think, MAmoun?
Yeah, great paper, and thank you for choosing it. I posed the question to Ahmed and to the panelists that one of the things that this meta-analysis shows us is that the long-term mortality and amputation rate is really not affected by any of these interventions. It's the same whatever you do. It's a balloon, it's a stent, it's the drug. So should we be chasing patency numbers, or we're serving the purpose? And I know a lot of by doing the solving the immediate problem, or be it wound care or rest pain or etc., and whatever happens with that artery happens, because the amputation rate and the mortality is the same whatever you do.
Well, I think due to the lack of other outcomes as secondary or primary, like quality of life and the experience of the patient and the other symptoms of the patient. So it's very hard to tell. I mean, it might not affect on the level of, or on the prospect of amputation or death, but it might affect with the quality of life, which is one of the downsides of this paper, which it wasn't mentioned or it wasn't compared in these studies. So I think further studying of further effect of critical limb ischemia and claudication might be conducted for further studies.
Roy, you have a question, right?
Yeah, no, I just want to chime in. I think this is a very nice paper. One of the best things about this paper is the quality of research that's being done in vascular surgery. This is a paper that used to be published only in Circulation, and to see it published in a vascular journal, I think is really, really nice. And then, like Ahmed did a great job of summarizing all the findings. My only comment, or two comments, is one, they use target lesion revascularization as an endpoint, and I think we all can agree that target lesion revascularization is very subjective, and I would caution people to use that. That's it's a good thing for data, but it's a cardiology based thing, and really doesn't tell us the endpoints that we want, which is amputation or primary patency. And the second thing I found very interesting is that they did 6 months and 3-year follow-up, which I think is very important because a lot of people with, especially with critical life-threatening ischemia, the average life expectancy is 5 years, and to get something just past 6 months to a year is something we all struggle with. We all want the longer patency rate, but sometimes just knowing that you could get somebody through 6 months to a year with a limb is very important. Those are my comments, and very nice paper to review. Thank you, and good job, Ahmed.
Thank you. Thank you, Dr. Lee.
Thank you, Lai. But let me ask you, Luai, I mean, can you tell in specific, like if you have a FEM-POP, like, SFA occlusion or stenosis, what can to use?
It's very user dependent and very, like Jamal said, it's very subjective to the lesion. Sometimes you want something to debulk and then you're going to stent, and this is the problem with studying peripheral vascular disease. It's multifocal, multi-level, and multi-type lesions. Calcified lesions are very different than simple soft plaque atherosclerotic lesions. We haven't figured out how to classify this in a simple manner where we can look at it objectively.
I agree with that. The reason why it's very hard to run a study because a lot of variation, as you said, depend on the calcifications, the lesion, the links, the location, the runoff, the inflow. There's a lot of variations, But it's nice to have all those tools. And the second thing, a lot of tools when the study was not available or was not included, like absorbable stent now. We have retrievable stent. There's a lot of things keep coming to the market. But it's nice to get I think it's good to give you like a guideline or like a wide idea of what's going on, and devices you have it, in between your hand. But at the end, I think it's individualized, decision, what you use. This is what I think.
Like Mamoun said, at the end of the day, it doesn't make a huge difference what you use. But as long as you get the.
So if that's the case, then you should try to go for the least expensive and the one that has the not that far outcome from the most expensive. So we clearly feel like balloon angioplasty alone. All the studies have shown that plain old balloon angioplasty will have a lower patency rate, etc. But if you have in the tibials, if you just have a long segment and you deal it with a balloon angioplasty, and you can heal that wound and get the patient back in action and with the least amount of expenses, and you get away with it, and everyone's happy.
And also sometimes you think, Jamal, is does it worth this extra? The prices, because prices, some of them are unbelievable.
Yeah.
So do you think does it worth this price for this 5-6 months extra patency? Does it really worth it? Especially if you're dealing with a wound, as you said, or critical limb ischemia.
Yeah.
So I always have this struggle: does it worth to put this money for this few, or slight better say?
I think once you start dealing with patients who are paying themselves for the cost of the procedures, you realize that you end up very often offering the patient what they can afford more than what the best outcomes may show, but you still can achieve what is needed to get them over the hump or over the problem they are facing. Thank you.
Yeah. Thank you. Any other question from the audience, from attendees? Any questions? Okay, for the time's sake, thank you, Ahmed. You did a very good job. I really appreciate your help. So we can move to the next paper now.
Thank you, Dr. Samuel. Thank you, all the panel.
So our next paper. Sorry, Samuel, do you want to introduce the next paper?
No, you can introduce this because this is
sure. So our next paper
Mariam.
is by Mariam Shtawi, who's a vascular fellow of the Royal Medical Services in Amman, Jordan, and she's going to be talking to us about or sort of reviewing a paper for us, which is endovascular versus open surgical approach in patients with acute limb ischemia, a systematic review and meta-analysis. I'm glad that both papers are meta-analysis today, which is, extremely useful and beneficial. Over to you, Mariam. If you may share your slides with us and start your presentation.
Miriam, we cannot hear you yet.
Mariam, you're probably muted.
Nope, sorry.
Assalamu alaikum.
There we go.
All right, here you are.
First of all, I would like to thank Dr. Samir for giving me this chance, and thank you, Dr. MAmoun, for your support all the way long. The paper that we are talking about today is a critical appraisal of contemporary evidence of endovascular versus open surgery for acute limb ischemia, systematic review and meta-analysis, Journal of Vascular Surgery, 2025. Can you see the slides?
Yeah.
Core findings and clinical implications. This is 2025 meta-analysis synthesizes heterogeneous, low certainty evidence, a grade very low from 26 studies, number population around 214,683. Finds no difference in early amputation, but suggests a long-term mortality benefit of endovascular therapy. Identifies a critical trade-off, reduced hospital stay, infection versus an increased intracranial hemorrhage risk. Primary limitations, conclusions are constrained by the underlying evidence base, 85% observational data. Recommendations, the study clarifies equipoise, but is not practice changing. It serves as a powerful call for targeted high quality RCTs. Rationale for this synthesis, an enduring clinical dilemma. Acute limb ischemia demands urgent high stakes decision making. Prior to this analysis, evidence was fragmented, small scale, single center studies with conflicting results and significant methodological heterogeneity. The gap, a lack of level 1 evidence to guide the choice between minimally invasive and open surgical strategies. This study aims to provide a quantitative grade informed synthesis to inform practice and future trial design. Assessment, the strength point of this study, protocol and reproducibility, Prospero registered, PRISMA adherent, comprehensive, multi-database search. Statistical model, appropriate use of random effects model anticipating heterogeneity. Evidence grading, transparent application of the grade framework. Inclusion criteria, broad inclusion may increase clinical heterogeneity, quantified heterogeneity, high I2 statistics for key outcomes must temper interpretations. Inherent limitation, grade outcomes are low/very low, reflecting the input data. The fundamental constraints, quality of source studies, evidence, graphical representation showing 4 RCTs, gold standard, supporting a large body of 22 observational studies. Key critique: the meta-analysis inherits the biases of its components, selection bias, confounding by indication, and treatment allocation bias prevalent in observational cohort. The implications: the pooled estimates, while statistical powerful, may not represent causal effects. This directly explains the very low grade rating. What the evidence show: efficacy, safety, and trade-off. The study synthesizes outcomes with varying levels of confidence as graded by the grade framework. On efficacy for preventing early amputation, but with very low signal emerges for improvement long-term survival with endovascular therapy through still based on low certainty evidence. On safety, a defined trade-off exists. Endovascular management is associated with statistical significant increase in the risk of intracranial hemorrhage. What the evidence shows, again here on the resources used, a more consistent finding is that endovascular approach correlates with a meaningfully shorter hospital stay and an outcome supported by evidence of moderate سامعيني? Is there a voice?
Yes, yeah.
Oh, okay. Publication context and potential. The Journal of Vascular Surgery, GIF 3.6 Q1, the official journal of FRCS, lends credibility, but it does not override methodological critique. The authorship: lead and senior authors from a major academic vascular surgery division, no declared conflicts of interest. Publication context and potential files. Critical point: the study represents an academic synthesis of availability without commercial influence, but its single institution authorship may reflect a specific academic perspective. Limitation and clinically, the lack of patient stratified data cannot answer which approach for which patient. For example, Rutherford 2A versus Rutherford 2B, embolic or versus thrombotic. Treatment heterogeneity, pooled varied endovascular technique, CDT or MPT, and open procedures. The apples and oranges critique: high statistical heterogeneity suggests combining clinical diverse studies. Conclusion: the findings are hypothesis generating, not practice definitive. Thank you. The reference: Abu Jamea, MM et al., Vascular Surgery 2025.
Thank you, Mariam, for a good presentation. I know in meta-analysis studies, it's easy to get sucked into the statistical sort of analogies and details. But can you, in sort of simple words, put to us what the meta-analysis did? You know, what did it look at, and what conclusion did it come up with?
The conclusion of this study, actually, it reflects what we are practicing in the real hospitals, in our real hospitals. So I think it added nothing, and it lacks a lot of points, like the amputation, the primary outcomes or the early outcomes. Like the amputation, they are not specifying which amputation. Is it a toe? Is it below knee or above knee amputation? And the time frame. Since when or after what time after the intervention, either if it is endovascular or it is an open. So it has many weak points, as they mentioned, because they cannot collect the data and the The documentation is poor, as they mentioned in their meta-analysis and systemic review.
I would be interested to hear from the panel what they thought of, the meta-analysis, and will it affect practice in any way? Dr. Samer?
Yeah, it's a nice paper, but I don't agree with that. They conclude that it's no different. For me, I mean, endovascular for acute limb ischemia, really, it's much better at limb salvage than an open repair, because in acute ischemia, I mean, if you do endovascular, you can really clean up the artery much, much better than surgical, interventions. And we see that in our practice, So for us, still endovascular is our first line treatment for acute lower limb ischemia. So I think, as far as I know, I think the limb salvage is much better with the endovascular than. So I was surprised to see there's no difference here. But again, this is a limitation when you do meta-analysis. But for us, when patient comes with acute limb ischemia, at least it's like, advanced. Even if it's advanced now, because you don't have to do, the second thing, we don't do thrombolysis anymore. So even if we get with a delay ischemia, we still do endovascular because we do mechanical thrombectomy these days. So we don't delay 24 hours in thrombolysis like the old fashions. But we found that with endovascular, intervention, we get a better outcome, cleaning the artery, and much better limb salvage. So for us, still endovascular is a first line of treatment.
Anything to add, Dr. Abdullah?
Well, I think there are some valuable points in this paper that there are different ways of doing things, and they all can lead to reasonable outcome. Clearly, it shows the concern about intracranial bleeding and hemorrhage outside the area of treatment. But as mentioned by Dr. Koussayer, that people are shying away from using thrombolytic therapy. I think from a clinical perspective, everyone has to see what's available at his or her institution. If you don't have suction and mechanical embolectomy at your institution, then you have to resort to other forms of open surgical treatment. At the same time, what this paper does not bring up is the issue of hybrid approaches, because you can also, with a little bit of a minimal sedation and local anesthesia, explore the superficial femoral artery and do a lot of work and still end up with very good results at a very reasonable, with a very reasonable outcome and very reasonable cost. I mean, some of these suction and mechanical thrombectomy devices cost $7,000. Again, I talk from the cost perspective. You're going to find out that this is not going to be very affordable. So if I'm dealing with someone who has a major embolic situation and with a huge load of thrombus, I may find it easier for me to start with a hybrid approach and, in view of the tools available to me, and clean as much as I can of the artery, and then add to it over the wire balloon embolectomy and thrombectomy, and with all various techniques, and get the job done. So these are my takes on it. Thank you.
We would love to hear from Dr. Guzman Tania, who's on board with us.
Yes, thank you. I'm sorry because I joined a little bit late. I came from the Gulf Aorta Summit. I just arrived very, very tight. It is a great paper, again, as meta-analysis, and all the comments that were said, we have to read it carefully. It is applicable to all the regions? No. What we apply in Europe is not what we apply in the Middle East, is not what we apply in the US. And also, there is a lot of variance, I think, in between institutions. You might be very skilled using a Rotarex, you might be very skilled using Penumbra, you might have very good experience with thrombolytic therapy, but maybe you are not going to have the support in your institution to do a fibrinolysis in an ICU bed. So, again, I think endovascular therapy is an excellent option. But sometimes it's not applicable. Sometimes maybe it is not available. And we really need to offer what we can in the circumstances or the places that we are working. And again, here in the Middle East, I think we have very different options. Not all the institutions, facilities, even in the same country, we find a lot of variety of what we can offer to the patient. So we have to take also that into account. We might be very skilled, but we might not be able to offer the best to our patient in that institution. That's my lecture, and to take
Yeah, that's quite extremely beneficial and clear. Dr. Luay, the last word on the topic.
So again, Mariam, excellent job in presenting. Really, really good.
Thank you.
The slides were very clear, and hands off to MAmoun for mentoring you. He did a great job. What I'm going to have a different aspect on this. I'm very, very impressed that this paper came out from majority Arab countries. If you look at the authors, Mariam, Hamad, Abdulaziz, Mariam Darwish, it's really, really, it makes me proud, and I think this is what PAVSS does, and this is what PAVSS wants to do, is to support the people from the region to publish this type of thing. So that's the first thing I really found interesting about this paper. And the second thing is really, really well done. The data may not be there, and Mariam did a lot of good things of saying, they didn't show this, they didn't have the amputations, and I think Jamal is spot on. We do a lot of hybrid procedures, but that's the data is the data, and they did an excellent job of the way they presented it and the way they collected it. So those are my two things. And then just to end with what Samer said, the future, I think, is for endovascular technology. They cost $7,000, like Jamal said, but they really do a good job. The basket therapies for embolectomies really clear out. And if you look at the new data, we presented stuff at VAM, a 93% or 95% success rate, including the artery, just with endovascular therapy. 50% of that, 50% of the time, all you need is the basket. You don't need anything else. So a lot of this is old data. I think the new data, the new technology is going to come out and make a clear difference. That's all I have today. An excellent job, Mariam, again.
Actually, you also have a great experience with aspiration, with the aspiration techniques. Can you dwell on that? Because I've heard, I've watched some of your presentations on that. Can you comment further on it? Are you using it for aortic? Let's say you have a patient with an aortic saddle embolus versus someone who has a popliteal thrombus with tibial involvements. How do you any different way in the managing these patients?
So it again is like Tanya said, it depends on the resources you have, your own institution, and depends on the comfort level of the person taking care of that patient at that time. Even in my institution, people treat these things very differently, depending on the comfort level of endovascular versus open. The saddle embolus is probably, like Jamal said, it's going to be a hybrid procedure, cut down, and embolectomy is probably the fastest way. We are starting to do basket thrombectomies on those with protection devices. The popliteal, if it's just embolic, we tend to do basket thrombectomies. We publish a lot on the suction thrombectomies. With the basket thrombectomy devices with a 95% success rate, I think that's going to be very difficult. We found that's very difficult to achieve that with pure suction. You need something that's going to grab the clot and pull it out. Just pure suction is probably a 50% success rate. It doesn't have enough suction. You need to break up the clot and suck it out, and the basket pulls it out very well.
Can I just mention something? Sometimes you don't have to put a lot of money to invest. As Dr. Jamal said, you can do a hybrid. Like last time I got acute ischemia. I mean, the problem with the Fogarty, it go only to peroneal. You cannot do select, especially below the knee. But now with the over-the-wire Fogarty, really you can go and do clean 3 of them. And last time we don't even have over-the-wire Fogarty. So what I did the wire to the selective to anterior tibial with a long sheath, and then I bought a regular Fogarty through the sheath, and then it thrombectomy through that. So sometimes you don't have to invest too much. You just have to change your technique, and you can still get a good result, you know. So I think hybrid repair, I think is also is a good result, you know, because as Jamal said, it's local anesthesia, small incision. But the most important, you have to have an intervention, like an angiogram during the procedure to see, because people depend only on back flows. It's horrible, you know, you cannot depend. You need to have completion angiogram. And, or sometimes you just small cut below the knee and clean up the artery, you can do that. So as I said, you don't have to invest like a lot sometimes, you know. So it depends what you have. But I think pure surgical, I don't think is enough, but hybrid or pure endovascular should be the best, I think.
I must follow up on that because this has been the technique that we have been using for a while rather than the over-the-wire balloon. We get a long sheath down to the popliteal.
Yeah.
We canalize the tibials. We've written about it. We've described that technique. We get the wire down, and then you get a size 6 French sheath down into the anterior, posterior, or peroneal artery. And the actual plain old-fashioned Fogarty catheter is much nicer to handle than the one over the wire with balloon and pulling and holding the wire, etc., etc. So I think what we need to all admit is that we need to be good. We need to become good at doing both endo and open, and that's the best way you're going to get the best results for these patients. Thank you.
I think the thing I like about starting with endo is always you have the option of conversion. So if that doesn't work, there's something else you can do. While the opposite probably is not true. But once you're open to surgically remove a clot and, there is a problem with it, you probably lost the endo option. And there is a question from the floor. So, sorry, let's see. What is an SF? Muhammad Maslamani is asking, in which clinical scenarios is endovascular revascularization preferred over open surgical thromboembolectomy? For example, is an endovascular approach favored in patients with systemic lupus, particularly with overlapping antiphospholipid syndrome? Dr. Samer, would you like to offer an answer?
I think the age of the thrombus, I mean, we talk about an acute ischemia, it depends, because like last time we did it, we get like a white clot, like embolized from the heart. There's no way you can remove this endovascular, So sometimes it depends what you emboli. It's a thrombosis, then endovascular is the best, but it's emboli from the heart, sometimes could be really a thick, or from atheroma in the aorta, would be a very old, thick clot. Then no way you can remove the atheroma. So, and sometimes we do endovascular, even endovascular, you can find a clot, it cannot be removed because an old thick clot came from somewhere else, or atheroma, and then you have to do surgical.
Yeah, the question also sort of raises the point of one of the most difficult situations in acute ischemia, which is the antiphospholipid syndrome, and that is like a different kettle of fish. It's so difficult to deal with, whichever means you choose, and probably the emphasis on treating the thrombophilia rather than the actual just occlusion. Dr. Kozman had a comment.
Just on that, I really don't want to be reopening a graft. If I have a FEMPOP bypass that is thrombosed, of course, I prefer to do lysis or suction. Aorta by FEM that is occluded, a groin that has been redone or has a patch, it is where I always try to do endovascular techniques to try to avoid exposure of the graft for infection. And this is for the benefit of the fellows and the trainees. I will try to not to expose that to reduce the infection rate. Personally, if there is a thrombophilia or a patient with that it is not matching very well. I really don't understand from where is coming the thrombi, and I'm suspecting there might be a thrombus or somebody's clotting a lot. I don't want either to be opening. That's my personal approach to reply to that question.
Also, I just need to mention that if you have acute on chronic, I think endovascular should be your primary, because this way the artery is already diseased. You can do thrombectomy. So if I look at the other legs and he has a long history of like claudication, then he came with acute ischemia. This is acute and chronic. I think this patient endovascular, because open, you cannot help this guy with an open. So this is, for me, is a frank endovascular approach for him.
With our time almost up, I'll turn over to Dr. Koussayer for closing remark.
Okay, thank you very much. We like first to thank our presenter, Mariam and Ahmed. You did a great job. Really appreciate that. Thank you very much. I'd like to thank the panelists, for Dr. Luay, Dr. Guzman, Jamal, MAmoun, everyone really. And the most important, we like to thank our attendants for taking time and stay with us. And thank you very much, everyone. And we try to do it like every other month. The plan is with the PAVSS to do like every month one activities. So we'll do 1 month webinar, and next month we'll do journal club. The other things from the attendees, if anybody has a nice paper to discuss, just send to me privately, so maybe you can consider to discuss it next time. But thank you, everyone. Thank you for everyone, and hopefully to see you next month, inshallah.
Thank you, sir.
And Ramadan Kareem.
Thank you.
And Ramadan Kareem from
Yes.
now. Thank you,
It's a
everyone.
pleasure.
Thank you.
Yeah.